in the chat box. Let me just, okay, let's get moving. So we'll just start with first just an examination quiz. So if you have a single second heart sound and no murmur, what do you think of? Single second heart sound, no murmur. Anyone? You can just send your answers to everybody. So a single S2, no murmur. Any answers? Why everyone's so quiet? So if you have a single S2 and no murmur, yeah. So this just put your answers to everyone so they can, yeah, you put it to everyone. So if you have a single S2 and no murmur, you think of pulmonary atresia, right? And the other thing is transposition of the great artery. So TGA intact septum. So we'll have also single S2, no murmur. Single S2 and a systolic ejection murmur, what do you think of? So you'll think of, yes, you'll think of a top physiology, right? So it could be tetralogy of Fallot. What else? So tetralogy of Fallot. What else will give you a systolic ejection murmur? DORVCS, single ventricles with pulmonary stenosis. So Fallots physiology and single ventricles with pulmonary stenosis. Single S2, ejection systolic murmur, diastolic murmur, what do you think of? What's your differential diagnosis? Systolic ejection murmur, diastolic murmur. So you murmur. So you think of TET absent valve, right? Because that's going to be your classic and your truncus with regurgitation. So TET absent valve and truncus. Single S2 continuous murmur, what do you think of? Single S2 continuous murmur, we think of pulmonary atresia with NASCAR. So as you can see here, in a blue baby with a single S2, so once you detect that it's a single S2, then looking at the type of murmur, you can actually come to pretty much a conclusion of some of the things. So pulmonary atresia with NASCAR is your classic for single S2 with continuous murmurs, of course duct as well. But generally pulmonary atresia is more associated with the NASCAR. Single S2 these. What about a blue baby with a split second heart sound? What do you think of? Blue baby split second heart sound. So could be a non-obstructed PAPVC, right? Could be Epstein's. What else? And could be a common atrium. But commonly you're going to think of unobstructed PAPVC. Blue baby with heart failure. What do you think of? Blue baby heart failure. Blue baby heart failure, yes, that's right. Truncus and TGA can do that. And also think of pulmonary atresia with multiple NASCARs. That would be the other thing to think of. And of course, Epstein's with significant PR. Now, what is the difference between a cyanotic baby and an acyanotic baby in terms of operability? What is the key difference between cyanotic heart disease and acyanotic heart disease when it comes to operability? As you know, in operability, if they have failure to thrive, active precordium, signs of heart failure, we think of that they are operable. So what's the key difference between the two? Is the cyanosis itself. So in an acyanotic heart disease, cyanosis will generally mean they are not operable. So if you have a large VSD and they have a blue and cyanotic in club, they are in Eisenmengers. Whereas if you look at a cyanotic heart disease like a transposition VSD, blueness or presence of cyanosis does not mean that they are inoperable. But there are some situations where if they are blue, some cyanotic heart disease, that if they are blue, it suggests that they are inoperable. Can you name those? So which are the cyanotic heart diseases that if they are really blue, And I'm talking about cyanotic heart disease with pulmonary hypertension, obviously. I'm not talking about cyanotic heart disease with low QC. Cyanotic heart disease with PAH situations, where would it be if they were had a SATs of 75%? You would say, no, I'm not going to operate. Which situation? Truncus. That's right. Truncus is one. And what's the other one? So Truncus and single ventricles with PAH. Now, TGA VSD, I will tell you, can be a little bit of a different story, so we'll get into that. So, when you have single ventricles with pulmonary hypertension or truncus with pulmonary hypertension, they should generally be pink if they've got low pulmonary resistance. If they become blue, that means that suggests inoperability. Now, let's look at TGA VSD. Okay. Now, but just before that, with truncus, what are the two features that suggest operability with the truncus arteriosus? Two features that suggest operability. So, no, two features that will tell you that this patient is operable, that you can operate on the truncus. Of course, if they have branch PA stenosis, then yes, their lungs are protected and they're operable. But let's say the truncus who does not have branch PA stenosis. So the first feature is absence of cyanosis. So pink. If they are pink, and the second is flow reversal in the arch in the absence of truncal regurg. And yes, you're right, a wide pulse pressure in the absence of what? A wide pulse pressure in a truncus suggests operability in the absence of truncal regurgitation. So you have to always quantify. So a wide pulse pressure in truncus, if you have a wide pulse pressure and you have no AR, that means that your pulmonary resistance is low and the blood is able to go off into the lungs, and therefore you have your wide pulse pressure. So if the truncus is pink, has a wide pulse pressure without AR, has flow reversal in the arch without AR, or not AR, without truncal regurg, those are features of operability. Now a TGA or a VSD, we'll move on to a TGA VSD. When do they become typically inoperable? When does PVOD happen? When do they become inoperable typically? So when we say 2 months would be a little young, the first decade would be a little old, right? So in TGA VSD, and when we talk about PVOD, what we mean is the Heath-Edwards changes. So when you look at it, at 2 months, you'll have changes in about 20% of the infants, okay? But after 1 year of age, about 80% of them will have grade 3 or 4 changes. So when you look at it, the PVOD, by 1 year of age, 80% of them will have pulmonary vascular obstructive disease. Now, having said that, the changes are occurring at 2 months, at 3 months, and that's why you operate on these kids early. You operate on a TGA VSD by 4 to 6 weeks because you don't want any changes to occur. You don't want parts of the lung to get damaged. So PVOD can occur from 2 months till 1 year, 2 years, but after 1 year of age, the majority of them will have PVOD. By 2 months, it's still only 20%, but obviously you want to prevent even that 20% from getting pulmonary vascular obstructive disease. Now, in a TGA with a VSD, what suggests operability? When would you be comfortable saying, say you had a 2-year-old with a TGA VSD, when would you be comfortable sending this patient to the OR? If PS, if there's PS, by the way, they will not develop Eisenmenger inoperability. So they will always be operable. When I'm talking about operability, I mean when the PA pressure is high and they damage the lungs, you cannot operate because they've got irreversible pulmonary vascular disease. So in TGA with a VSD, what tells you they are operable? Well, yes, of course, if they have normal PA pressures, but TGA large VSD will not have normal PA pressures. TGA, so guys, when we talk about operability, what we are always talking about is a situation where PA pressures are systemic, where PA pressure is same as the body pressure, as same as aortic pressure. That is the situation in which operability comes into play. So a TGA with a VSD, what suggests operability? So that means they've got high PA pressures, but you want to know that if you do a switch and close that VSD, the PA pressures will drop down, right? So what are the features of operability? Are you all first year fellows? Sorry, before, maybe this is because I see a lot of new names. How many of you are first year fellows? Just joined? Can you say yes, yes, yes with your first year? Savita, just stop recording for a minute. You have your pulmonary artery, right, coming from your LV. And you've got your aorta giving rise from your RV, right? Now you have a large VSD. So aortic pressure, let us say, is 100, right? If aortic pressure is 100 in a TGA, what is RV pressure? RV pressure is what? In a TGA, if aortic pressure is 100, what is RV pressure? 100, right? So RV is 100. Now, if there is a large VSD, what is LV pressure in a TGA VSD? It's going to be 100, right? So now LV is 100. Now, if there is no pulmonary stenosis, pulmonary valve is normal, what is going to be PA pressure? 100. So everyone gets this concept? When you have a D-TGA with a large VSD, or D-TGA with a large PDA, or D-TGA with a large AP window, in any of these situations, as long as there is no pulmonary stenosis, your PA pressure is going to be systemic. So, in a D-TGA with a VSD, with systemic PA pressure, over time, because of this high pressure and high flow, the lungs are going to get damaged. And in TGA VSD, in fact, the lungs get damaged earlier than in a regular VSD. And that is why you operate on these kids by 1 to 2 months of age. Because they have high pressure, they also have a mix of some cyanosis, and they have unlimited QP. It's also considered that the oxygenated blood, see, what is the blood going to the PA? It is oxygenated blood, right? You've got LA to LV and streaming to PA. And the oxygen radicals are thought to have further worsening of pulmonary vascular obstructive disease. And that is why TGA VSD, you saw Heath Edwards changes, 20% by 2 months, 80% by 1 year. They have very early damage of the lungs. So sometimes in India, you'll get an older kid who's like 2 or 3 or 4 with a TGA VSD, and you have to decide, is he operable or is he not? Now, he may be blue. One, because of vascular disease, but he may also be blue because of mixing, right? So that is why TGA VSD is different from a truncus. Where in a truncus, if he's blue, he's not operable. In a TGA VSD, he may be blue because of mixing. What do I mean by that? Where does the IVC and SVC blood go in a TGA VSD? To which ventricle do IVC and SVC blood go? IVC and SVC blood go where? To RV, right? So they're going here. So blue blood is going out to aorta. Riyanka, you can put to everyone and everyone will see your answers. Now, where is the pink blood from the LA is going out to pulmonary artery, right? Now, where does the mixing occur? Typically, where is the mixing occurring? At the which level? At the atrial level, right? So, if blood comes back from pulmonary vein and then it goes to ASD, it goes out to RV. So, now pink blood goes to aorta and patient will be pink, and hopefully some of this blue blood will go out to PA. So, if you have a TGA VSD and you don't have an ASD, right, what happens is the pink blood streams preferentially to PA, blue blood goes preferentially to aorta. So, even though they may be operable, because of the streaming effect, they may be blue. And therefore, cyanosis does not mean that they are inoperable. Does that make sense? Cyanosis doesn't tell you that they are Eisenmenger in TGA VSD. Now, when you have, therefore, when you're looking at operability, in a TGA VSD, the things that suggest operability are, one is if they have signs of heart failure. Is there a law? Because what happens is as your vascular disease increases, your pulmonary vascular disease, then the blood doesn't go into the lungs. If the blood doesn't go into the lungs, it can't come back to LA. So typically your heart failure disappears. It's the same as with a large VSD. By 4 or 6 weeks, pulmonary resistance falls, they're in heart failure. Then they have pulmonary vascular disease, and then the heart failure goes away. So TGA VSD, if you have signs of heart failure, it's a good thing. As the pulmonary vascular disease increases, cyanosis will increase, but as I said, inadequate mixing may also be causing the cyanosis. So you can't only look at that. What you have to look at is what is the direction of the VSD flow. So in a TGA VSD, if the VSD is going right to left, does it tell you there's high PVR or low PVR? If it's going right to left, it tells you there is low PVR, right? Because it's going from right ventricle to LV to PA. So if, unlike in your VSD, if it is you have a right to left shunt and a regular VSD, you think of Eisenmenger. In a TGA VSD, if it's right to left, it means that there is low PVR, and that is a good sign. So the echo features of inoperability would be if the patient's VSD is going left to right, then that tells you he's inoperable or his pulmonary resistance is very high. If he doesn't have left heart dilation, because now it's going left to right, you don't have all that extra blood coming back into LALV to the pulmonary artery, and absence or reduced pulmonary venous return. These are all the echo features of inoperability. Okay. I'm going to, I'm really sorry, I didn't realize it was all first year fellows. So anyway, I'm going to zip through today, and then we'll go back to kind of the basics in the E-classes again. But just quickly, this is an angiogram. Anyone spotter? If you can see this play, this is a pigtail catheter. So this is an, of course, so just watch this one. What is the diagnosis? So this, where is this? This is a AP view multi-purpose catheter going from IVC, RA, LA into the left upper pulmonary vein. And where is that blood coming back? That's coming into the, watch where that is coming back. Now watch this one. So where is this coming back? This left upper pulmonary vein is draining where? Into the, you can all see that? This is the left upper pulmonary vein here, draining into this structure. What is this structure? This is the LA, right? So generally the LA will lie on the left of the spine and higher up, right? Now watch this angio. Watch this angio as it's playing here. Let me stop now. I want you to watch this catheter and this contrast where it's going, okay, as it plays on the right of the spine. And then give me the diagnosis. So, okay, this is an LV gram, intact septum, normal coronaries, no PDA, no quart. Okay, watch that catheter. The right coronary catheter in the right upper pulmonary vein. Where is that draining? So this is fast, but just watch. Yes, so it's draining into the right atrium. So what is that diagnosis? So it is a PAPVC. So you can watch here, this how it's draining. This is a PAPVC to the right atrium, that's right. So this is the pulmonary vein and the contrast is coming in here. Remember we saw the LA line here. So this is a PAPVC to the right atrium. So what would you do? This is not, in which situations do you see PAPVC to right atrium? In which situations? In sinus venosus, so correct. Now this patient does not have a sinus venosus ASD. It is an isolated right-sided PAPVC. So, what would you do? You want to operate, you want to give medicine, you want to wait. What do you want to do? So if the QPQS is more than 1.5:1, then you would operate. If it's a single vein, you can wait. So if it's only one pulmonary vein, no right heart dilation, there's no need for intervention. Generally, if there is right heart dilation, that suggests QPQS is greater than 1.5. If there's no right heart dilation, that tells you that QPQS is less than 1.5:1. Okay, all clear of that. So if two veins are draining, yes, in the sense if you've got like a scimitar, right? So say you have the whole right lung draining into RA, then you'll have right heart dilation, and then yes, QPQS will be high, they can get pulmonary vascular disease, it's like an ASD, you would operate. Okay, all clear? I seem to have given you the answer here. Okay, so diagnosis here. Common atrium. So you can see that this is the, everyone see that mitral valve, tricuspid valve, and then no interatrial septum at all. Then when you put color on, you can see that there is grade 2 tricuspid valve regurg, there's some mitral regurg, right? So this is a common atrium. What are the associated lesions you see with common atrium? So you can get unroofed CS, yes. So systemic venous anomalies basically. What else? Anything else? So whenever you see a common atrium, you look for AV valve regurg, right? You look for left AV valve, right AV valve, you look at the PA pressures. So, and then you look for heterotaxies, you look for systemic venous anomalies, you can look for your syndrome, you can look for DO, so it can be associated with systemic vein anomalies as well as pulmonary venous anomalies. So all that should be looked for. Common atrium, commonly seen with asplenia syndrome, the asplenia heterotaxy, and you can also see it occasionally in DORV situation. So look for heterotaxy, look for systemic and pulmonary venous anomalies. Okay, all clear? Now when would you operate on a common atrium? And the answer is 6 to 12 months. So why do you operate on it earlier than an ASD? Why? Normally, when would you operate on an ASD? Let's say you had a large secundum ASD. When would you operate on it? So 2 to 5 years, right? Yeah. So why do you operate earlier on a common atrium? Large shunt, okay. Associated MR, okay. Why a higher risk of PH? So that's true. They have a higher risk of early pulmonary vascular because of admixture. Because so what happens? What does hypoxia do to the pulmonary arterioles? What does hypoxia do typically? Like for instance, when you're in the ICU, right, and you have patient is hypoxic, what happens to the pulmonary pressure? Hypoxia is a powerful vasoconstrictor of the lungs, right? So you get an increase in PA pressure. And that's one of the reasons in the ICU, if you're having a pulmonary hypertensive crisis, what do? You bag them, you give them oxygen, right? So in common atrium, you've got mixing. Patient will be a bit blue. You're getting systemic, because of this mixing, you're getting some blue blood also going out to lungs and body. So you're overall little hypoxic. So it's a combination of a large atrial shunt, AV valve regurgitation, which can worsen the shunt, and hypoxia or cyanosis, I should say, rather than hypoxia, cyanosis, which all this leads to earlier pulmonary vascular damage, and that's why you operate on a common atrium much earlier than you would on a ASD. And it's also unfortunately a little more complicated because apart from separating it, you need to look for things like unroofed CSs or left SVC draining directly into the left atrium, or PAPVCs, and so on and so forth. Okay. Now, again, I hope can you see this? You can't see this angle. This is a RAO pigtail catheter in the root of the aorta. I guess you could think Truncus. I won't blame you, yeah. But you see how it's going around, right? It's like when you see Truncus, you'll just get from that aorta, you'll get these two left PA and right PA. You look at this structure, whatever this structure is, right? It's coming. PCS is what? It's coming like this, like this, like this, right? Sandeep, what is PCF? You said PCF? CAVS? Coronary cameral. So this is a coronary cameral fistula. So you can see here, you have a very dilated, you see it's going in where the place where you see your coronary artery go. So it's coming in the position of a coronary artery. So this is a coronary cameral fistula. Now which is the commonest type of coronary cameral fistula? Commonest. Commonest coronary cameral. Is it to RA? To RV? So commonest is to RV. So the 40% to right ventricle. Next common is right atrium, 26%. Then pulmonary arteries, 17%. Then SVC, CS, left atrium, left ventricle, all these other places. Okay. Now this one is a coronary cameral fistula echo. I just want to show you this. Where is it draining? And which coronary is draining where? You see that? See something going behind the aorta? It's a short axis view. So which coronary is that? So it actually, see, it's coming. Let me annotate this for you. So okay, let me quickly ask you this question. So say you have, this is your aorta, right? In a short axis view on echo, which coronary artery is this one? RCA, right? That's right coronary. So you've got your right cusp, you have your left cusp, this one, and then this is your non-coronary, right? This is your NCC. So from here comes one, the left main, right, like this. That goes like this, and then that goes like this, right? So what coronary is this one? This one. Which coronary is this one? What is that one? So that is a LAD, right? What coronary is this one? That's the circumflex. Because why is this LAD? Because it's going upwards and it's going anteriorly, and the LAD runs anteriorly. This is more posterior. So this is going in posteriorly and in the left AV group. So this is your circ. So now, keeping that in mind, watch this echo again. Because this is something, that gets missed, which is the left circumflex to right atrium. Okay? Because sometimes you just think it's a CS running there. So watch this. Watch right behind the aorta. So that's your aorta. Watch that structure. Many times you think that's a coronary sinus, but that is a dilated left circumflex and then draining. Where the CS kind of opens, it's draining right into your right atrium. So keep that in mind when you see this unusual structure running through an LA. Then you carefully go back and look at your left circ, at your left main. The left main will also get dilated. And if you look here, this is just to show you how it's coming off. And again, it's within the LA, this structure. Sometimes gets confused for like some weird atrium or a CS, but think of a coronary cameral fistula in that location. Now, what are the modes of presentation of coronary cameral fistula? How can they present? So they can be asymptomatic if they're small. They can have a murmur. Okay, what's the murmur that they can have? What kind of murmur? So they can have a continuous murmur if they are draining into which structures? RA or only RA? What about if they drain into RV or SVC, RV, PA? So remember that murmurs are nothing but gradients. Murmurs are just gradients, right? So if this is your aorta and your pressure is what's your pressure in your aorta? 100 by, let's say, what's the pressure? 60, right? So let's say RV. What is the pressure of a normal RV? Normal RV pressure? 20 or 30 by how much? 25 by, what is end diastolic? 5, 8, right? So let's say, so you see there's a gradient in systole, there's a gradient in diastole. So in coronary AV fistulae, you will have a murmur if the AV fistula drains into right atrium, right ventricle, pulmonary artery, SVC, CS. Where will you not have a murmur? If it drains into where no murmur? LV. Because in LV, what will be the murmur be? In LV, what will you get the murmur? So remember, what is your LV pressure? 100 by, say, 10, right? So, correct. So you see in systole, there's no gradient. In diastole, there's a gradient. So you get a diastolic murmur, which sounds like AR. So the mode of presentation, patient can be asymptomatic, may just present with a murmur, okay, or they can be symptomatic. What are the symptoms with coronary AV fistulae? What are the symptoms of coronary AV fistulae? Obviously, those tend to be in the larger ones. So it can be heart failure. Okay, what else? Other symptoms of coronary AV fistulae. Dyspnea, okay, if they have a volume load of the right ventricle, PA pressure goes up, so on. Angina, because there's a steel. What else? What else? So angina, right? So these, you need to all know all these modes. So one, small, asymptomatic, large with steel. So ischemia, angina and heart failure. Okay. Then you've got the patients who have long-term, untreated. They can, now they're ischemic hearts, right? This coronary fistula keeps getting bigger because aortic pressure. Then it gets all tortuous. So the heart, because of this steel of the myocardial damage, they can have arrhythmias, chronic ischemia, and then because of this thing growing, they get aneurysms of it. That's coronary camera fistula. They can have sudden death because of rupture. They can even get endocarditis. So in older patients, your complications become aneurysms, sudden death, endocarditis, arrhythmias. That's why that is the importance of intervening on coronary cameral fistula. Small patients asymptomatic, larger ones, of course, can present with myocardial ischemias or heart failures with wide pulse pressure. Okay, all clear on this? And this was what we said. So depending on how it drains. So for instance, if they drain into right atrium, then they act like ASDs. Drain into pulmonary arteries, they act like PDAs. Drain into the left atrium, they act like MR because there is a volume load into LA. And if they drain into left ventricle, the physiology is similar to that of AR. Okay, clear on this? Now, can you name 3 acquired causes of coronary AV fistulae? So the 2 examples I showed you are not acquired; they are congenital AV fistulae. But can you name some acquired causes of coronary AV fistulae? So could be post-surgical, okay. Not necessarily VSD, but okay, myomectomy, for instance, when they remove the septum, rupture of rupture of an aneurysm, right? But that may not. Okay, trauma. Trauma can do that. You can have traumatic creation of coronary fistulae. Anything else? You guys have heard of radiofrequency ablation, right? So one is if you do septal myectomies or myomectomies for hokum, if you do a lot of muscle bundle resections like in tetralogy repair, and if you do radiofrequency ablation for accessory pathways, sometimes you basically burn through and you create a connection between the cavity and into the coronary artery, and that can cause a coronary fistula, trauma, and then things like endomyocardial biopsy. So again, you're punching and you create a connection between it. So these are all the different causes of acquired coronary AV fistula. Okay, I'll end with this last question because it's dengue season. So I ask you guys this often so that you all know this. Right. So what are the cardiac manifestations of dengue? Myocarditis. So what does it present with? So they can have it's not exactly dilated cardiomyopathy. It will be more myocarditis. They can have low ejection fraction. They can have bradycardia. How do you treat it? You do so it improves over time. So you have to just manage it. You can give them some inotropes and manage their function and so on, and gradually over time it tends to improve. That's the good part of dengue. So ECG sinus bradycardia, they can have ST changes. Echo will show low left ventricular ejection fraction. They can have pericardial effusions, and you need to manage them with inotropes and time, of course, as they are replacing their platelets and so on, and this tends to improve over time. Okay, so with that I shall end. Savita, you can stop recording. So